So I just want to say a few words about the three women that will be joining me in a few minutes. Sylvia was first diagnosed with breast cancer in 2010. She was 48 at the time. She had a lumpectomy, and then she experienced a second diagnosis of breast cancer in 2019. And she decided to have a bilateral mastectomy followed by reconstruction. Ginny was diagnosed in 2019 at the age of 41. She had a bilateral mastectomy and decided to forego breast reconstruction. And she's excited to share how she made that decision and how she feels about it. And finally, Amy was diagnosed in 2021, so very recently, just a few weeks shy of her 45th birthday. She had a bilateral mastectomy and implant reconstruction. So thank you to all of these women again for being willing to be with us and to share their stories. And then once we're finished that discussion with them, Dr. Joseph Serletti, who is the chief of Penn Plastic Surgery and a plastic and reconstructive surgery with an expertise in breast reconstruction. He is a very experienced doctor. We're honored to have him with us. So he will join us after we have this conversation. Feel free to go to our website, lbbc.org, to see the full bios of all of our panelists. Nice to see you. Okay, so we're going to start. I'm going to ask each of you one question, and Sylvia, I'm going to start with you. If you could first just say, tell us one line about who you are, when you were diagnosed and your treatment, and what reconstruction you had.
I am a two-time breast cancer survivor. I was diagnosed 2010 and 2019. I'm an author, I'm a mother, grandmother. I decided to have the first time I decided to have the lumpectomy, they removed the knot. And then the second time I ended up having the flap. In 2019, after the double mastectomy, I decided to have the flap versus the implant.
Great, thank you. And Amy, why don't we go to you next? Do you remember the questions?
Yes, sure.
Okay, great.
I'm Amy. Nice to meet everyone. I am a wife. I'm a mom of three, and I'm a breast cancer survivor. I was diagnosed in December of 2021. I had 8 rounds of chemo, a double mastectomy, implant exchange, and 25 rounds of proton therapy post implant exchange. I finished all treatments in October of 2022.
Congratulations.
Thank you.
It's great to have you with us. And finally, Ginny.
Hi, everybody. My name is Ginny. So I am a breast cancer survivor. I'm also a mom, a wife, an advocate, a snark queen, an aspiring artist, and a flat fashionista. Essentially, I like to think that I'm all of the things. And I was diagnosed in 2019 at 41 years old with stage 1 hormone positive, HER2 negative breast cancer. I had a bilateral mastectomy, chemotherapy, radiation, and then had a sapling oophorectomy after that. So that's when you have your ovaries and your fallopian tubes removed as well. And after all of that, I opted not to have any reconstruction.
Great. Okay, so we're going to go right to the question. And Ginny, I'm going to stick with you. So the first question is, are you happy with your choice, and why or why not?
I am very, very happy with my choice. My story is a little bit unique. When I was initially diagnosed, the plan was to actually have a mastectomy straight to implant. But as we went through additional testing, as that happens when you're first diagnosed, we discovered that the cancer had spread to my lymph nodes. So I was going to need radiation, and the plastic surgeons at the time in that practice recommended that we not do any kind of reconstruction, expanders, nothing until after I had finished the radiation treatment. So it was, over a year later, after I had all the surgeries and all of the treatment, before it was time to go back to the plastic surgeon and have that conversation about whether I wanted to go ahead and do implants or attempt some kind of flap surgery. But I've been living that whole time as a flat person. I had tried all the clothes on in my closet and thinned it out and determined what worked for me and what didn't work for me. I had started to embrace my body and my scars, and I really didn't want to go under the knife again. It just was not for me. And my breasts were not part of my identity anymore. My flatness is what's part of my identity now. And part of what makes me unique. I'm not going to say that every single day I don't wish that I had boobs, because you know, sometimes you see somebody that looks really good in that outfit, and I just know that like I could never wear that. That wouldn't work for me because of my body type. But those are pretty fleeting thoughts in the grand scheme of things. But I do think it's important to acknowledge that it's okay, no matter what decision you make, to sometimes think about what might have been.
Right. Thank you. And thank you for sharing that so openly, and for, you know, knowing what you want and doing it. So Sylvia, how about you? Are you happy with your choice, and why or why not?
I am happy now, but that have not always been the case. And it was because I did go through quite a bit. I went in expecting to do the flap and be done, but the left side did not work, and I didn't want an implant. So I ended up with one anyway. So right now I have my tissue on the right side, and on the left side, I ended up with an implant. And sometimes, you know, when I look at myself, I can see the differences. So with that, I'm just a little, you know, iffy about it. But overall, I'm okay with it. But if I had it to do all over again, that I would just go with the implants and be done.
Okay, I hear you. And how about you, Abby? I know you're the newest to this, so how are you feeling about your choices?
I feel very happy with the choice that I made. At first, when you're given all of the information, it seems so overwhelming because you're in a spot that you never wanted to be in, and then you're faced with all these decisions you have to make. Luckily, you know, I had a great team, and I was able to talk to my nurse, and we went over all of the different choices that were laid out. I wasn't a candidate for the flap surgery, but I was for implants. So I did go with the implant. And the issue with the implant was I didn't know when they did the mastectomy, they did find cancer in my lymph nodes. So they did have to go ahead and remove those, which changed. I was supposed to just do regular radiation on the right side, but then it changed to my whole chest wall and my underarms and my neck. So it was proton therapy, got switched to it. So they had to take out the expanders and put an implant in, and they went over the risks that I might have to get another procedure after that, because I had to get the proton therapy for the entire chest wall, and it can destroy tissue and an implant. But luckily that didn't happen for me, so I don't have to get a second surgery to get these implants removed. They're fine, they're all intact, and it's all great. So I didn't have any complications with any of the surgeries. My scars are healing. So I'm kind of putting this all in my rearview mirror. I just wish my hair would grow as quickly as everything else. But I'm happy with the decision I made. I wanted to get some sort of normalcy back, my body back to what it was. I know it'll never be what it was, but moving forward, I am happy with the decision I made, and I'm ready just to put this in my rearview mirror.
Okay, thank you. So Ginny, let's go back to you. And you talked a little bit about the factors that went into you making this decision, but I'm wondering, were your doctors supportive? Like, what kind of roadblocks did you run into as you made this decision?
I was actually very fortunate, and I since have found out that other people haven't had the same experience. The first consultation I had with the plastic surgeon before any kind of treatment had started, flat was presented as an option. It was presented at the end after all the other options. But I specifically remember the doctor saying to me that, you know, sometimes women come in here, even younger women like yourself, and this is the first and only time I ever see them, because ultimately they decide that they want to go flat. And just having him verbalize that, I think, put it in my brain, because it wasn't something that really had occurred to me prior to him actually saying that, like, oh, I guess that could be an option. I didn't really think about that. I had only been thinking about implants, for example. So having that from the plastic surgeon and having that in my brain from the get-go, I think really helped me solidify that decision. I was also really fortunate that my oncology team was really supportive of my decision. My family has been really supportive of my decision as well. And it was always my decision to make. It wasn't anybody else. There wasn't a lot of noise that I had to deal with when I was going through all of that, which was great. And now I can't remember what the original question was.
No, that's fine. That you answered the question.
And apologies, I have a dog and the door doesn't latch, so I have to go back.
It's okay. I have a dog too. I know many of us are in that situation. So Sylvia, you talked about, you know, some regret. So what do you wish you had known prior to making your decision? Like what would have helped you make a decision that maybe you would have been happier with?
And my surgeon, I will say my surgeon was very good. And he did tell me that there would be a possibility that it did not work. And if it didn't, he would have to put the expander back in. But I didn't realize that I went in the hospital thinking, I'm going to get this surgery. He's going to do the tissue transfer and I'm going to be okay. I knew I was going to have to go in ICU for a little bit. Well, my story, I ended up the original operation. Then I went in and the left side didn't take. I had to go back and have emergency surgery, not once, but twice. So that was 3 times I ended up in OR for this one surgery. I ended up with 3 different surgeries. And then on the back end, about a month later, my expander that had to be put back in got infected. So then that was a 4th surgery. So I have some pretty extensive scarring from hip to hip on my back where they used tissue the 2nd time. And then of course, my breast scarring. So that's a lot of scarring, that's a lot of surgery. So for that reason alone, had I known, I definitely would not have chosen that route. Because that was a lot for my body to go through.
Right. And do you feel like you didn't really know that you knew this was a possibility, but you didn't know the extent of what it would be like, right?
Right. The extent. He told me there was a possibility, but I should have asked more questions as far as if this does not work, what does it entail to correct it? And that may have changed my thinking about going forward with it.
Okay, thank you.
I just want to jump in here with what Sylvia said. Because I waited as well, I was able to talk to a lot of other survivors that made all of these other decisions about whether they wanted to stay flat or get reconstruction. And talking to them and hearing their stories also really helped me solidify my decision. For me, I didn't want the additional surgeries because it's generally not a one and done type of thing, but I wouldn't have necessarily known that until I was talking to some of my peers.
Right. Yes, we know that the community is so important. So Ginny, while I have you, because there is a question in the chat from someone who asked, she has heard for some women who decide not to reconstruct that your chest can become concaved. Has that happened to you or?
Yes,
Okay.
I am slightly concave. I could, if I wanted to, go in and get some fat transferred, but again, I don't want to do any more surgery if I don't have to, and I'm happy with how I look aesthetically. Just a note, I had my surgery in 2019, and I had small breasts to begin with, so I did not have a lot of extra skin, even though we thought maybe we were going to do implants or something later on. So my situation is a little bit unique there. I think women with larger breasts, there would be more skin around and you wouldn't necessarily have that aesthetic effect unless you went in and specifically asked for aesthetic flat closure. And that terminology didn't exist until 2020. So now you
Yeah.
have language to go in and ask for that, which is really great.
Yes, I'm really glad you mentioned that. That is really important. So thank you. So I know we only have like, I'm going to give us 2 more minutes and then time goes so fast. But Amy, since you're the closest to going through this, like how did your doctors explain the timing and your recovery from breast reconstruction, and how well did that match what you experienced?
I was expecting for the implant exchange, because you have to wait a little bit of time in between your mastectomy. You have expanders in, and then they do the implant exchange surgery. So I feel like after the mastectomy, I could do anything now. The implant exchange, it's outpatient. The recovery was like nothing. I don't know if any of you had a port put in, but I kind of compare it to my port surgery. So you're sore for a couple days, but you're back at it. I was walking out and about. I have a young son, and I was out with him, and you wear a like kind of like a brace. I'm losing the word. That's another fun thing. I with my brain after chemo, you wear just a compression garment over the area, and you're good to go. I wasn't down and out, maybe a day in bed the day that I came home from surgery, but it was very easy. And it was a lot easier than I had anticipated. They told me it was going to be much easier, but I didn't believe them. But it was quick and easy, and I'm glad that I chose to do it.
Okay, thank you. And we understand chemo brain, so
Thank
you're
you.
doing great. So there are a lot of questions, not surprising, they're mostly medical. So I'm going to just start because we want to focus on decision making.
Sure.
So let me start with a question for you, which is, what are the major issues doctors and women should discuss when they're thinking about breast reconstruction options?
So I think that as a surgeon seeing a new patient, you have to evaluate the patient, evaluate what things are going to happen after their cancer surgery in terms of radiation, chemotherapy. And you have to see the patient, look at their body habitus, and then, discuss with them first what all the options are in breast reconstruction. So implant-based, 2-stage implant-based, direct-to-implant, autogenous reconstruction from the abdominal donor site, other donor sites. And, once you've gone through that full menu, see what direction the patient is interested in moving in.
Okay. And how do you talk to your patients about potential complications? I mean, I know it's a scary time. These women have been diagnosed with breast cancer. So how do you kind of set them up so they sort of know complications might happen?
Yeah, sure. So look, basically there's 2 ways to reconstruct a breast: implant-based and autogenous-based. And certainly autogenous is a more complex, surgical operation. It's a longer operation, but the success rate is actually much higher than with implant reconstruction. So so we tell every patient, look, whatever we set out to do in the beginning may not work. And this happened to Sylvia. It may not work. The one thing we always tell the patient is, if it doesn't work, you will end up with a successful breast reconstruction. It may take us a couple of operations, but it's going to happen. But I tell patients in this general discussion of implant-based versus autogenous-based that the implant reconstruction fails 3 to 4% of the time, and it's based on infection. If an implant gets infected, we try to treat it with antibiotics. A lot of times we're successful, but if the infection will not be treated, if it's not treated successfully with antibiotics, you have to remove the implant. That doesn't mean it's the end of implant reconstruction, because we typically wait 8 weeks, 10 weeks, and then, go back to either putting a tissue expander in or an implant in again. So, and I will say that with basically every implant infection that we've had and lost the implant, we ultimately got a successful implant reconstruction in our patients.
Okay.
With autogenous reconstruction, where we're taking tissue from the abdomen, separating it from the body with the artery and vein, bringing up to the chest, hooking it up to an artery and vein in the chest. At Penn Plastic Surgery, where we do more of this than any place in the world, frankly, our failure rate is 0.6%. So our success rate is 99.4%. So it's rare that we lose a flap, but it happens. And you have to let the patient know it, because it can happen.
Okay, well, that's good. It's good that that information is shared. I am going to take, there's a lot of medical questions. I know people
Sure.
have those, but I'm just going to be careful how many I ask. But one person is that, since we talked about the aesthetic flat closure, two things. One, someone is asking the body habitus, which I guess means your body type.
Yeah.
That doesn't really have any bearing if you're choosing not to reconstruct.
No.
And can you go from having an aesthetic flap and then say, oh, I do want to reconstruct like a couple of years later? Is that possible?
Say that again. I don't know.
So if someone decides not to reconstruct.
Sure.
and-
Oh, yes. Oh,
Yeah.
yeah. Okay. Yeah. Yeah. So we've always said this for many years. There's two ways there's two timing mechanisms for breast reconstruction: immediate, which is done either initiated or done completely at the time that the mastectomy is done, or delayed reconstruction, so that the patient has a mastectomy and comes for a delayed reconstruction, whether implant-based or autogenous-based. Autogenous meaning the patient's own tissue. There's no time limit to delayed reconstruction. We can do it 6 months after the mastectomy. We can do it 20 years after the mastectomy.
Okay. Right.
Okay.
So women should know you have options, right?
Yeah, always options, always.
So there is a question wanting to know the difference between saline or silicone implants.
Mm-hmm. Sure. So I would say 95+% of the time we use gel implants. There's been a lot of research done on negative effects of having silicone gel implants, and it's called breast implant related disease. Nobody has been able to prove, no scientific organization has been able to prove that there is a link between silicone gel implants and breast implant related disease. But I believe it exists. I believe there's a very small percentage of patients who definitely have some negative reaction to implants, but it's very small. And we tell patients that, there is this potential. And when we see someone like that, we remove their implants, and their symptoms usually get, very promptly better. So other than this very, very small group of people, we have gel implants and we have saline implants. If some patient is really adverse to the potential of this rare breast implant related disease, we'll offer saline implants. When I see a patient in the office and they ask me, what is your opinion about saline versus gel implants? I always say this, and I mean it, from the bottom of my heart. If my wife was in this situation and she asked me, should I have gel implants or saline implants, I would tell her have gel implants, because the gel is just much more natural. The gel under the skin, of the breast skin, feels a lot more like a breast than the saline implant. Okay.
Okay, thank you. So there's a lot of questions about radiation and implants.
Oh, yes.
So can you
Absolutely. I deal with it on a weekly basis. So our current algorithm, meaning our plan, is the following. If we know someone is, so in the past, if we knew someone was going to have radiation, we would, put in a tissue expander underneath the muscle, expand them through the radiation, or expand them prior to radiation, let them have the radiation, and then after radiation, take out the expander, put in an implant. And most of the time you did that, you got a very unsatisfactory result, meaning that the implant had significant firmness. It's called capsular contracture. And it's very, very hard to get a decent result in implant reconstruction with that situation. Over the last couple of years, we've been putting both implants, meaning direct to implant, where we put the implant in right away, or a tissue expander in. We've been putting it on top of the muscle, and we've been putting some acellular dermal matrix on top of that. And what we have found is that those people who need to go on to radiation, they don't seem to get the same firmness that we saw when either the expander or the implant was underneath the muscle. And we believe that it's the radiated pectoralis muscle which is really contributing to the capsular contracture. So that's radiation in the implant scenario. So if I know someone who wants implant reconstruction, whether it's 2-stage with expanders or direct to implant, and we know they're going to be radiated, for sure we're going to put it in what's called a prepectoral position. So we put it on top of the muscle and underneath the skin. And this has worked out, so far pretty well. If someone's going to have the flap, we just go ahead and do the flap. The flap tolerates radiation reasonably well. There are, and I'm not going to share this publicly, but we work with several radiation oncologists who are outstanding at radiating a breast that has had a reconstruction, and they understand how to do it so that the cancer is treated, but there's minimal impact on the reconstruction. So,
Okay, that's good.
It's a complex topic. Hopefully I answered it reasonably clearly for everybody.
Yeah, there's always a lot of questions on that. So there's another question about, if you have breast cancer in one breast, will insurance pay for a reduction in the breast that has not been impacted by cancer to get better symmetry?
Yeah, so everybody should know there's a thing called the Federal Breast Act, which was sponsored by Senator Alphonse D'Amato from New York. And when I was at the University of Rochester before I was at the University of Pennsylvania, that's where we really started doing, in the early 90s, free flap breast reconstruction. Senator D'Amato came to visit us at the University of Rochester as he was putting this Federal Breast Act together. And one of the things that we talked about, which he had already figured out, was that it was going to mandate that all insurance companies cover balancing procedures on the opposite breast. Prior to this, if someone wanted a reduction, they had to pay for it themselves. If they wanted an augmentation, they had to pay for it themselves. If they wanted a breast lift, they had to pay for themselves. Every patient on this webinar should understand there is a federal law that mandates that balancing procedures are covered by your health insurance company. And so if you get denied, I would call your local congressman, because they can't deny it.
So there are some questions about tightness after having expanders in, and after several years still having a lot of tightness under the arm. Is that common, and what causes that? Or is there any way to avoid it?
It's not common, but we see it. It's not an easy thing to treat. a lot of times, so a lot of times what patients are having is post-mastectomy pain syndrome, which is sort of like if someone has a leg amputation and they have phantom limb pain, it's the same thing. There's a lot of nerves that go into the breast and they're cut as the breast tissue is removed. And these nerves, which usually settle down in most patients, can remain very active, and they cause this sort of chronic pain. People describe it as a vice across their chest or a band across their chest. When we see a patient with this, one option is to remove the implants. I tell them we can remove them. There's no guarantee that this pain can get better. And I've been down this road with a number of patients, and in the end, if we can't solve it surgically, they really need to enter a pain management program.
There's another attendee saying she just had her exchange surgery very recently, and she's just not happy with the results. So do things change over time? Is it sort of what it's like at the beginning, the way it's always going to be like? What can she expect?
I would say that in general, an implant-based breast reconstruction looks its best the day you do it, and it tends to change to the negative over time. So if it's not looking good right now, it's probably going to need some revision. And I'm just being totally upfront and honest. And whereas an autogenous reconstruction, when we use the patient's own tissue, it can look very surgical, meaning it doesn't look much like a breast, but by doing nothing over time, your own tissue tends to soften itself out, and it definitely gets better over time. So I've often referred to this as the realities, the late realities of breast reconstruction, that an implant reconstruction, it can look great at 6 months or a year, and if you look at it 5 or 10 years later, it doesn't look anywhere as good as it looked then, and that's okay. I mean, a lot of unfortunately, the thing about implants is if you have implant reconstruction, you're probably going to have 1 or 2 revisions over your lifetime, which is fine. Autogenous reconstruction is just what I said. It can look very surgical, irregular, a little depressed here and there. And if you just, wait over time by doing nothing, your own body and your own tissue has a way of smoothing itself out. So,
right. So back to making decisions, which this program is really about. When you talk to patients who choose implants, do you tell them ahead of time, you probably will have to have these replaced? I mean, sort of what information do you share with women up front about what to expect?
So what I say is, the current recommendation is that we get an MRI now every 5 years. And I say, we'll do it every 5 years. And my personal feeling is there's no reason. A lot of people come and say, I've heard I have to have these replaced at 10 years. That's not true at all. We get an MRI at 5. If the implant looks good and the patient is happy, you don't have to do anything. Same at 10, same at 15 years. My feeling is when you get to 20 years, we should probably replace the implants. Why? Because when I replace implants that are younger than 20 years, they're almost always intact. And this is both for cosmetic surgery and for breast reconstruction. When we see someone who comes in with implants that are over 20 years, one side's intact, the other side is ruptured, and it's an asymptomatic rupture. So I think my personal feeling is these things can last for 20 years, but at 20, you should come in and have an implant exchange.
And would a woman know that her implant had ruptured? Like
usually not. It's usually asymptomatic.
Okay. So that's why the MRI is important.
Yes. Yeah.
Okay. So back to surgery, we have a couple of questions about who's a candidate for nipple-sparing surgery, and does that work? Is that a good option for women who've had breast cancer? Obviously.
Yeah. I mean, we do it all the time. I would say you can't have an overly droopy breast, and you can't have a, D to double D or beyond breast cup. So if you have an A, B, or C breast with not a lot of droop, and you have to have a breast surgeon who is comfortable doing this operation, there's no reason, and the tumor can't, again, this is a decision between the patient and the breast surgeon, because the tumor cannot be near the nipple either. So, but we do nipple sparing all the time. So, and we do it for both implant-based reconstruction and autogenous reconstruction, either one.
Okay. So there's a couple of questions. So this is really back to decision making. Some women who are now considering getting areola or nipple tattooing. Is that something you talk to your patients about? And is there a certain time that it's good to do that? Like, do things move around that you want to wait till things settle, or sort of how do you talk to patients about that?
Yeah, I mean, we won't do it before 6 months, 6 months after completing implant reconstruction or 6 months after autogenous reconstruction. And it's usually later than that. But so there's two ways to reconstruct the nipple. There's a two-step process and a one-step process. So the two-step process makes the most realistic appearing nipple. And what that is, whether the patient has implant or autogenous, is, and typically if all they're having done is the nipple, we can do this in the office under local, so that they can drive themselves to the office. We can do this and they can drive themselves home. So the two-step process is under Novocaine, we make a nipple projection in the office. You let that heal, and about 6 or 8 weeks later, we have a tattoo person in our office who's very skilled, and she will then put the color in. So that combination of the nipple projections made surgically and the tattoo, it makes a very realistic nipple. A lot of patients do not want the two-step. They don't want the projection of the nipple. And so the alternative is just come in for the tattoo person to do a 3-dimensional tattoo, which again is an office visit. They drive in, it takes about, I think, 20 or so minutes per side, and they have a 3-dimensional tattoo, which it looks good. It doesn't look as realistic as the two-step method.
Got it. Thank you. And I know for our national audience, if you want to find out where you can get this done in your location, you can contact us and we can help you figure that out. So some people are asking, and I guess maybe everybody's a little confused. Is it better to see a reconstruction surgeon or a plastic surgeon? Or are they really one and the same?
No, that's one and the same. That's
okay.
One and the same. One and the same. No question.
Okay, great. That's an easy one to answer. And then I love this question. We have someone who says, I'm 86 years old. So how old is too old for reconstruction?
There's no age limit. I mean, we have definitely reconstructed people in their 80s. I've seen people who come in with an old implant or something and they want it changed. So we've written at least 2 papers about age and autogenous reconstruction, which is the more complex method of reconstruction. And we looked at our experience in patients 60 to 80, and then patients 59 to 20 something. And there were no differences in the medical or surgical complications between the older group and the younger group. If you're 86 and you're pretty healthy, there's no reason why you can't have breast reconstruction. There's a thing called the ASA class. It's the American Society of Anesthesiologists. And it gives you a risk assessment for having surgery. So, an 86-year-old who either takes no medications or maybe just has some high blood pressure, they're an ASA of 2. that's most people are an ASAF2. There's no reason why that person can't go ahead and safely have breast reconstruction. So it's not age, it's your overall medical health.
Right. That's great. Thank you. So another person is asking, she met with a surgeon and this surgeon advised against a DIEP flap procedure if she intends to get pregnant in the future. How risky or what kind of complications could happen if a woman does get pregnant after doing that procedure?
So same thing. We've written this up from our own. Again, we sit in a very fortunate position where we've done more DIEP flaps than any place in the world. So we've written almost everything about it. And we looked at a few years ago people who got pregnant after DIEP flap surgery of our patients. And I can't remember, there were 20 or 25 people. They all had successful pregnancies. There were a couple of twin pregnancies and one triplet, which is like crazy. And we looked at it from our Rochester group as well. And the thing that we learned is most of these patients are delivered by C-section. And I think because of the scarring in the lower abdomen, it just doesn't distend like in a normal person. And so, a lot of these people had C-sections, but a few were able to deliver vaginally. So we don't really consider it because our experience has been so positive that patients clearly can get pregnant. And I'll never forget, I had one patient in Rochester who had a unilateral, youngish woman, unilateral mastectomy, free flap breast reconstruction. About 6 or 8 weeks after surgery, or maybe it was a couple of months, she clearly got pregnant in the post-operative period. And she, so she was our earliest patient after surgery. She did fine.
Okay. And for the DIEP flap, you can get the fat from your thighs as well. Like there's other places in your body, right?
Yeah. So our number 2 go-to place for other tissue is the thigh. It used to be the buttock, but that leaves a pretty significant donor defect. In other words, it looks like, there's a significant loss of tissue from the buttock, even if someone wearing pants or a skirt. So, and it doesn't give the best tissue. So our second go-to place is the thigh, which actually works reasonably well.
And is the healing process easier? It seems
I
like
think
it
it's
would
actually,
be.
they seem to recover a little more quickly than the abdominal patients, definitely.
Okay. We're getting a lot of questions, and actually I've been hearing a lot about this recently, over the muscle, under the muscle implants. If you've had them under the muscle, can you switch them to over the muscle and they'll be more comfortable? Is it true that they're more comfortable? Like what are your thoughts about over or under?
So, today we mostly put them on top of the muscle. It's a lot less uncomfortable in the immediate surgical post-operative period because putting it underneath the muscle is not, it's painful. I think it gives you an overall softer result. Definitely a higher rate of rippling. So rippling is where you see the creases, from on top of the implant. But that can be treated with a secondary operation. Definitely, if someone's I said this earlier, if you're going to be radiated, definitely putting it on top of the muscle is good. We definitely have had more wound complications putting it on top of the muscle. So putting it underneath the muscle gives it some additional soft tissue protection. But I think all things considered, going on top of the muscle is the better way to go.
Okay, thank you. I have the question of how small of an implant can you get? This woman is an A cup, and so she wants to know, could she still get an implant to match?
The answer is yeah. They do. The implants go down to about 100 cc's, which would be an A cup. So yes.
Okay. And I'm just seeing if there's anything else. I know that I have not gotten to all your questions. But this is an important one, which I'll let you answer. You need a surgeon that is trained in microsurgery for a DIEP flap. Is that correct?
Yes.
Okay. And is that easy to find around the country? I mean, I know we're in Philadelphia, we have a lot of great hospitals, but is this something people can find pretty easily?
Well, I think, yes, it should be. I mean, when we started this back in 1991, I was probably the only person in New York State doing DIEP flaps. I mean, they weren't even being done in New York City. Now they're being done all over the place. So we've trained so many people to do this now that, whatever city you're in, you should be able to find somebody who's experienced in doing this.
Okay, great. All right. Well, let's bring Ginny, Sylvia, and Amy back. So just, in listening to this conversation, anything you want to add, or something you thought about? Or even looking at the questions in the chat, there are over like 100 and some.
I just wanted to kind of add on to what was mentioned earlier about the Breast Act, or the Women's Health Care Cancer. I can't remember what the actual
federal breast. It's the short term for it is Federal Breast Act. There
you go, the Federal Breast Act. I believe that's the same one that means that insurance has to cover prosthetics. They have to cover lymphedema sleeves. So, anybody that's recently diagnosed or goes through a mastectomy, even if you're flat temporarily or whatever, your insurance has to pay for a certain number of prosthetics. And you can get fitted at places like Nordstrom's pretty easily. And I think LBBC has some good resources as well that you can go through for that. So make sure, get yourself your money back, get reimbursed.
Absolutely. Okay. So I think what we're learning from just all the questions is that this is a really big decision, and it's a hard one to make. And, listening to Dr. Serletti, you can just begin to take in, there's just a lot of, they can be big surgeries, lots of decisions and complications down the road. So what advice would you give? I don't know, I'll go to you first, Jenny. What advice would you give a woman who is kind of trying to figure out how to sort through what's best for her? Because at the end, it's what's best for you, right? Not what your neighbor did.
Right. And as Dr. Serletti said, it depends on your body type as well. And you have to have a conversation with your surgeon. You have to find a surgeon that you're comfortable with, to be able to discuss all the options and what is work for you. I would say my advice, and this is hard, is know that you can take your time and delay reconstruction if you want to. The most important thing is saving your life. And I really appreciated that my medical team and my plastic surgeon, when I spoke to him, put a lot of emphasis on that. Like, this is about saving your life. Now that we've got the plan for saving your life, let's talk about saving you, or what's going to help you mentally, and how we get you back to a physical place that you want to be. But first and foremost, know that you don't have to be rushed to make those decisions, which ultimately are aesthetic, right? Immediately. You can wait. And if you're in the US, that delayed reconstruction is covered.
Right. But I want to make sure Amy's perspective comes in, because I know for some women, I know you have young children, sort of what you look like, not just because you have kids, it can be for lots of reasons, but tell us why for you it was important to do it right away.
For me, it was just trying to have some control over a situation where you have no control. So much is changing. You're getting hit with so much. So it was like one choice that I had in all this. And it was, I have to say, when I lost my hair for my young son, he still asked, like, when are you getting your hair back? So I think, all these changes to us physically, it's a lot for them. I mean, it was a lot for him. It's a lot for you to handle. So whatever you can take control of, that's what I did. So that's why it really meant a lot to me to have that back, just to have some semblance of who I was prior to all this. And I think just to let other people know, like, it's a personal decision, what you have to think about what it is that you want at the end of this, because, you know, you're going to go from being a patient to a survivor, you know, and patient mode is different than survivor mode, you know, you're afterwards. So you will come out of it. You are going to be, you know, on that other side. It's hard to think about when you're in treatment mode and you're in patient mode. But you know, so take your time. I think you have to just take your time. Don't be rushed. And like Ginny said, you can always reconstruct later if you want. But if it's something that you know you want to do, maybe get it done while you're in the mix of being in the hospital. You know, it might make it easier for you.
Okay, and how about you, Sylvia? What would you tell people, and what was important to you in making these decisions?
Something that I didn't do was connect with the breast cancer community and talk with women that had gone down that road, had been through those type things. I didn't do that. So I would tell anybody now that's diagnosed, talk to someone who's gone down that path and get their perspective. And that way you'll have some idea of what it feels like, what you're looking at. And then you get that support as well. So I would just suggest get more information. To me personally, I should have gathered more information before I made my final decision.
Okay, that's helpful. And we know it's hard to do. You know, you're diagnosed with breast cancer, you're making a lot of treatment decisions, it's overwhelming. So no blame for anybody, but I do think that's where connecting with people who can help you think about things and make the choice that's best for you, because again, there's no right way. So Dr. Serletti, before we do closing remarks, anything you want to add after being part of this? You could be here all night answering these questions, so I'm not.
That's all right. I think that the most important thing is if a patient is diagnosed with breast cancer and is interested in breast reconstruction, please make sure that you see a surgeon who does everything. So we here at Penn, we do everything. We do lumpectomy reconstruction. We do 2-stage implant reconstruction. We do direct implant reconstruction. We do DIEP flap. We do thigh-based. There's nothing we don't do, but we're not the only people. There's a lot of people out there like us who do everything. The majority of my colleagues in plastic surgery do not do everything. And so they may give you all these options, but they're going to steer you towards more likely implant reconstruction because most people are very comfortable doing that. So if you really want to get a fair assessment of what your options are and what it may really be best for you, please see somebody who is an expert in this, who offers everything so that they can give you all of the options and you can make an informed decision.
Yeah, that's a good point. We've definitely heard from a lot of women over the years that they go to a plastic surgeon and they have a favorite procedure, and that's what they're steered towards. So I think this is another area where getting a second opinion or even a third opinion is really worth it. We know some people live in areas where that's harder to do, but if you can, or you're able to travel, or think about that, or delay it, because it is something you're going to live with for the rest of your life, as you all can attest to. So I want to just thank Ginny and Sylvia and Amy for being with us this evening, for sharing your stories, for being so open. I'm sure everyone got a lot out of that. I want to thank Dr. Serletti for his expertise. Sad we didn't get to meet Dr. Rose, but next time we'll get her. And I want to just thank the audience. I have not obviously had time to really look at what's going on in the chat, but there is a lot of interaction. I can tell a lot of you are exchanging email addresses and phone numbers and connecting with each other, which is something we really value when we can't do these programs in person. You know, we used to be able to do these programs in person and women would run into the ladies' room and they would just lift their shirt up and they would show what they look like. And that was great. That's what people want to see. So thank you everybody for participating and for, spending your evening trying to get better informed and build community. I want to also thank again our sponsors, our signature sponsor, Natrel, and our benefactor sponsor, Penn Plastic Surgery. We ask that everybody fill out their evaluation. My staff actually reads every single evaluation. That's how we make our programs better. I think if you filled it out, you potentially could win something. So incenting you to do that as well. We will post this program on lbbc.org in the next couple of days. So if you want to share it with someone else or revisit it, it will be there. And please remember, we're always here for you. We have a helpline, we have programs throughout the year, and that is why we exist. So thank you so much, and wishing everybody a good night.